Good afternoon, everyone. Thank you for joining us today. Today we have Maria Rogg giving us a presentation. She's a registered nurse and senior clinical application specialist for neonatal products for Draeger. She has 36 years experience working in critical care with infants, children, and adults. She is passionate about education and sharing her knowledge with others. Thank you for joining us today, Maria. We look forward to your presentation.
So thank you, Rowan, for introducing me. And I am Maria Rogg, registered nurse with Draeger. And this is an overview of the updates that you're going to see for the 8th edition for the neonatal resuscitation program. Just a bit of disclosure, as a registered nurse and a senior clinical applications for specialist for Draeger, I have no actual or potential conflict of interest in relationship to this presentation. And just to remind you, this is not a presentation that will provide certification training for NRP. It's just going to be a review of the updates associated with the changes in the 8th edition. So just a little reminder what NRP is. It's the Neonatal Resuscitation Program, and it's jointly sponsored by the American Heart Association and the American Academy of Pediatrics. They provide education and materials with an evidence-based approach, and these materials are updated regularly for resuscitation of the newborn. NRP's goals is always to promote effective teamwork when caring for the newborn at the time of delivery. And this is for all healthcare professionals involved in the resuscitation. They offer a comprehensive education program that supports learning on several different levels. And this includes online learning with self-assessment and case scenarios, and in-person training that develops teamwork, leadership, communication, and hands-on skills. So this is the what it looks like, the new edition, 8th edition for neonatal resuscitation and some of their materials. And they're still offering 2 course level options. And this is based on the relevance to whatever the provider's role is during the delivery and resuscitation post-delivery. So there's NRP Essentials, which is for all providers who are involved in the care of a newborn. And this level uses those training materials from lessons 1 through 4. Then there's the NRP Advanced level, which is for providers who are responsible for more advanced measures in the resuscitation period. It could include giving medications, providing CPR, intubation, and they use materials from lessons 1 through 11. Advanced is renewed every 2 years. And everyone who is NRP certified should begin using the 8th edition materials by January 1st of 2022. New this year, they're offering 2 methods for educating the neonatal resuscitation program. What most of us are familiar with is the instructor-led traditional method, and this is where the learners complete the online learning assessment, and then within 90 days they participate in the instructor-guided skills and simulation portion of the course. And that's when they attain their e-credential. And just like before, renewal is every 2 years. What's new now is the RQI for Essentials. So RQI stands for Resuscitation Quarterly Improvement Program. And this new method is designed to really help learners retain the information and the skills. To help meet the need for more frequent training intervals and maintaining skills, the American Association partnered with Laerdal Medical, and this is in collaboration with the American Academy of Pediatrics and that's what created RQI. With this method, learners will still complete the online learning assessment as they have before, and then they participate in quarterly skills sessions, reviewing the essentials and using a neonatal simulator that provides real-time information to the provider as they're performing their positive pressure ventilation skills and other skills that they need to keep current on as they support resuscitation. At that point, an e-credential is attained, and they maintain this e-credential by attending these skill stations quarterly. NRP advanced providers participating in the quarterly RQI Essentials training would still renew their advanced learning every 2 years when they become due. Instructors also will renew their credentials when they expire, but they will still need to know these 8th edition updates and incorporate those into their training beginning in January. NRP focuses a lot of attention on teamwork, and they're continuing to do that in the 8th edition. And as a result, over the years, they've really come down to some key factors and skills that really support the resuscitation effort and that team approach. Some of these behaviors that they've identified is to bring that team together and discuss the resuscitation before the delivery. Identify the team leader and have that team discussion about those potential complications that might occur and determine a plan to all those potential complications. Identify all the team member tasks, and that includes who will be doing the documentation during the resuscitation. Verifying that all your supplies and equipment are there, present, functional is huge, right? And then communicate using the closed loop communication technique. So communication we find is super important in these situations, because oftentimes what ends up happening is an instruction is given, but then it's not carried out. So with the closed loop, it ensures instructions have been both heard and then understood. So let's take a look at the algorithm update. Here I have NRP 7th edition algorithm next to our 8th edition algorithm. And really they're just kind of minor changes, but they help support those who are in the resuscitation, and it gives us a more solid approach. So the first change you're going to see is just a wording change to our warm, dry, stimulate. The reason for this verbiage change is that it focuses more commonly on what real practice is in the real world. Also, a lot of times it may only be needed when you're doing a resuscitation and delivery to just warm, dry, and stimulate, and you may not have the need to suction. The other update to the algorithm is recommended by NRP is to begin using the cardiac monitor sooner. This is prior to the heart rate dropping below 60 now. Previously, a cardiac monitor was placed on the infant following a heart rate drop below 60. And now with the 8th edition, the placement of the cardiac monitor is to coincide with the placement of an ET tube or a laryngeal mask. This change really is to help validate and support the assessment of the heart rate as the caregivers are providing resuscitation. Because really the best indicator of successful ventilation is a rise in heart rate. And with so many things going on, that cardiac monitor can help validate what the heart rate is. When you're performing your resuscitation, if ventilation remains unsuccessful, consider Mr. SOPA in this period of time. If you're currently using SpO2 monitors to help you with your assessment of heart rate, just know that it can sometimes be unreliable when heart rate, there's so many things going on, whether you're intubating a patient or you're performing different things on the baby, it can cause jiggling of the pulse oximeter. So that's why they're also encouraging the cardiac monitor. SpO2 monitors are important and they provide valuable information. So we still want you to continue using those to assess the O2 concentration in the blood and to also help the caregiver determine the need for providing supplemental oxygen. The last minor change we see in the algorithm is the addition of every 3 to 5 minutes for the epinephrine action. The practitioner is following through with all steps of the resuscitation, and it can get busy, and so just a reminder of giving it every 3 to 5 minutes can be helpful. NRP 8th edition has made a few other changes to their guidance regarding epinephrine, and we'll talk about it later. It's about the dosage and flush volume. So one practice change that NRP 8th edition included this year is during the pre-birth assessment. One of our 4 questions has been updated. So we're still going to ask, what is the gestational age? Is the baby less than 36 weeks or greater than 41 weeks? Is the amniotic fluid clear? What are any additional risk factors that might be there? Things like preeclampsia, maternal hypertension, multiple gestation or fetal anemia. Maybe the mother has not had any prenatal care, or it's an emergency cesarean, or if you're using forceps or a vacuum assisted delivery, breech or other abnormal presentation. Maybe it's category 2 or 3 fetal heart rate pattern, or the mother has had some anesthesia or magnesium therapy, or perhaps it's placental abruption. All these things need to be talked about and a plan made. The new one now with 8th edition is, what is our umbilical cord management plan? And this replaces how many babies. This is because they're really trying to stress skin-to-skin contact with a mother, and can cord clamping be delayed? But they also want you to consider, what is the position of the cord? Is there a prolapse? And anything else where the position of the cord may be in utero. So I want to discuss now some reinforcement of our positive pressure ventilation skills, because ventilation of the newborn's lungs is still the most important and most effective step in neonatal resuscitation. Positive pressure ventilation is often provided when supporting ventilation of a newborn, and it's necessary when a baby is having apnea or bradycardia. If a newborn's heart rate is less than 100, positive pressure ventilation is required. It's interesting that 3 to 6% of newborns will require some type of ventilation support using positive pressure ventilation or CPAP. An important aspect for providing positive pressure ventilation with a bag valve mask is maintaining proper alignment of the head and the neck. To do this effectively, it may be necessary to have one person maintaining proper alignment of the head and neck, and also holding the mask tightly to the face. A second person would then provide the breath rate using either a T-piece resuscitator or a bag. And then a third person would be paying attention to the baby's response and assessing the baby. The need for ventilation support rises significantly when a baby is premature. And this includes babies delivered at 34 to 36 weeks. When we're providing ventilation support to a preterm infant, extra care should really be taken. This infant will need a lower inflation pressure and a device which can also offer PEEP. A T-piece resuscitator or a flow inflating bag are better at maintaining PEEP than a self-inflating bag. Practicing positive pressure ventilation using the equipment provided by your facility will help support you and reinforce your skills to help provide more effective and consistent ventilation for the newborn when you need to. So let's take a look at some of the forms that we can provide positive pressure ventilation with. The first one we're going to talk about is the self-inflating bag. With a self-inflating bag, it does not require compressed gas or a tight seal in order to reinflate the bag. Inspiratory pressure is then determined by how hard the bag is squeezed, and a pressure relief valve may help to limit the pressure to 30 or 40 centimeters of water, but these can be unreliable. You definitely should be using a manometer when you use the self-inflating bag, and these can be built in, or you can attach an external manometer. NRP recommends actually that the self-inflating bag be available at every resuscitation should compressed gases become unavailable, because you can still provide support with a self-inflating bag with positive pressure. Another mode of providing positive pressure ventilation is the flow inflating bag, or some people call it the anesthesia bag. This method requires compressed gases with an adequate flow, because the bag only fills when gases are flowing and the outlet is occluded. The practitioner adjusts the flow control valve to determine how much inflation pressure they're giving and PEEP. This method of providing positive pressure ventilation requires some practice, and some people are really good at it. Over time, and when working with real-time simulators or using it in practice, it can really give you the experience you need to be comfortable using it. A flow inflating bag can help those providers who are experienced assess lung compliance and feel the respiratory effort, as well as offer fine control of their pressures and small volumes. This method, though, can be a little difficult and more of a challenge for inexperienced people who are new to providing positive pressure ventilation. The last method we're going to talk about for providing positive pressure ventilation is the T-piece resuscitator. There are a multitude of T-piece resuscitators out there on the market today that can assist us as we're providing positive pressure ventilation to the neonate. Some of them are built into warmers, and there's many other extra features built in that support the caregiver during the resuscitation. But they all require compressed gases to provide the pressures and the breaths. Depending on the device in which you're using, you're going to adjust the flow of the gases using either a blender at the wall or on the device. They all have built-in manometers. And some advantages to using the T-piece resuscitator is that it allows the users to set their preferred pressures prior to delivery and easily make any changes to these pressures during the resuscitation efforts. Inspiratory pressure is set using a dial on the device while occluding the outlet and the cap of the T-piece. PEEP is adjusted by occluding the outlet of the T-piece and dialing the cap of the T-piece. Some things to consider when you're providing positive pressure ventilation NRP recommends that we start with a ventilation rate of 40 to 60 breaths per minute. When you're setting your inspiratory pressure, you should start with a pressure of 20 to 25 centimeters of water. Full-term babies may require a higher inflation pressure for initial breaths to inflate their lungs. And then a caregiver will assess and may be able to decrease the inflection pressure after those initial breaths. The initial setting for PEEP is 5 centimeters of water. The addition of PEEP during positive pressure ventilation helps to achieve stable lung inflation more quickly, and it also helps remove fluid and prevent air spaces from collapsing during exhalation. When we're providing positive pressure ventilation to premature infants, it's more likely that they will need some supplemental O2 in order to bring their SpO2 levels to their target value based on their birth and age in minutes. The targets for SpO2 are the same for both preterm infants and the healthy newborn. You can see on this chart, NRP recommendation for FiO2 is 21% for babies who are equal to and greater than 35 weeks, and 21 to 30% for babies less than 35 weeks gestation. We have a little change in the guidance for epinephrine dose, and that is NRP now recommends, in order to make it easier for everyone to remember what the dosage is, it's just one option instead of 3. So the new guideline for IV-IO epinephrine is just the 1 dose. And it's 0.2 milliliters per kilogram, which is the same as 0.02 milligrams per kilogram using the concentration of 0.1 milligrams per milliliter. Again, it replaces the choice caregivers had before, and that was a choice of, do they give 0.01 or 0.02 or 0.03 milligrams per kilogram. The ET tube dose for epinephrine is 0.1 milligram per kilogram, which is equal to the 1 milliliter per kilogram. And you will use positive pressure ventilations to distribute in the lungs. No flush is required. And this is if you can't get those IV or IO lines in. They say you can give 1 dose of the ET tube dose prior to IV or IO. The update for guidance for the epinephrine flush following the IV and IO dose has also been updated. And this is based on a study that was done where they found that 1 milliliter of normal saline following your dose of epinephrine may not make, it's not enough volume to help the medication reach the heart. So sometimes it's still in the umbilical line, or it may still be left in the liver. And so this extra volume of normal saline when you're providing the flush helps to get it where it needs to go. And this is for newborns of all gestational ages. So we need to consider reducing our risk of neurologic injury when we're providing our resuscitation efforts to this preterm infant. Our caregivers should understand that there really is a significant risk to this infant's brain and can be injured if they're born before 32 weeks. The reason for this is babies of this gestation have very fragile capillaries in their brain, and these capillaries are more susceptible to injury bleeding can result. And so we just want you to all be more careful and pay attention during the resuscitation process. For instance, when the blood pressure or blood volume rises, there is a rapid change in the blood CO2 levels. If venous drainage from the head is compromised, the risk for rupture can increase, and this can cause tissue damage, which may lead to a lifelong disability. On the opposite end of the spectrum, poor blood flow and oxygen deprivation can also lead to that brain injury, even when there's no hemorrhage present. And most of us realize too that too much oxygen in the blood can result in damage to those premature newborns developing eyes. So let's take some special considerations in mind as we're resuscitating the premature infant. One may seem like a no-brainer, handling the infant gently. But this also, it's pretty easy to forget when so many things are going on and occurring during the resuscitation process. But it's good to be reminded. Let's think about how we're positioning the baby. Positioning of the legs should remain below the head, and this is in order to help support cerebral venous drainage and lower cerebral pressure in the brain. Let's use the lowest pressures that we need in order to maintain the heart rate, but also while we're providing that positive pressure ventilation or CPAP. The higher the pressures, the more venous return is reduced, and that puts the baby at risk for a hemorrhage. We also want to monitor and adjust our ventilation using blood gases and our pulse oximeters, knowing that these rapid changes in CO2 levels also put our baby at risk for having bleeding in the brain. Let's consider how fast we are providing these fluids or volume expanders if they're needed, and giving them over to 5 to 10 minutes is what NRP recommends. So let's look, I mean, if you're given your normal saline flush, it's only 3 milliliters, but maybe we're not just pushing it in real quick. Maybe we're giving it a little slower for these infants. And care should be taken to avoid overheating the baby during and after our resuscitation. Again, after resuscitation, we also need to take some things into consideration for all those preterm infants and even infants who aren't preterm. We need to keep close monitoring of the respiratory effort and oxygenation, using monitors to monitor the heart rate and the temperature continuously, and also continuing to avoid overheating of the newborn. We're going to check our blood glucoses and CO2 and electrolyte levels often, assess our urine output, blood pressure, and the neurologic status frequently. If therapeutic hypothermia is recommended by the provider, it should be initiated as soon as possible. Birthing units and caregivers can identify these potential candidates and prepare the resources that they'll need to begin provide cooling for this infant who might need the additional support. And then set up transfer to a unit or a facility, or as soon as they can, where they can be managed with ongoing care. The last practice change that the NRP 8th edition came up with is really great because it's going to allow the team to have more time. The NRP updated this guideline for when to stop resuscitative efforts based on information that was shared by the International Liaison Committee on Resuscitation. LCOR reviewed multiple studies for resuscitation, and that's when they came up with the 20 minutes versus the 10 minutes we used to have as a guideline before. What they did was, in their findings, they found that this extra time will allow for the survival of some newborns that previously would have had some significant abnormalities, now are surviving and thriving. It will allow for the team to have more time to perform all of the steps that they need, that follow the steps of the process of resuscitation, and balance their time of maybe deciding, when should we stop? How long have we been doing it? Have we been doing it too long? This 20 minutes allows them more time to finish everything they need to do. It also gives the team time to determine those individualized decisions on the newborn. There are so many advances today with medicine and in NICUs and with neuroprotective care following the birth of an infant who might have had some type of neurologic trauma, that there's a better chance for good outcomes following a resuscitation. And it also offers the team a chance to talk with the family regarding the care of their newborn. So many times we should be involving these families in the decision-making process, and you just feel like you've run out of time. So this will helpfully allow for those discussions to happen more often. So let's do a quick review and go through what we've talked about today. Remember, training as an individual and as a team is going to reinforce our knowledge and skills that we need to support and prepare for these newborn resuscitations. Assessing the need for resuscitation and the delay of cord clamping is encouraged. And looking at what our cord management plan is prior to delivery is suggested. This is all to promote that skin-to-skin contact with mothers as soon as we can after birth. Ventilation support is our top priority for a newborn who needs assistance after the birth. And the most important indicator of an effective ventilation is when we see that rise in heart rate. We're going to use a cardiac monitor to help us validate the heart rate and assess the response to our resuscitative measures. And this is prior to or coinciding with intubations and prior to compressions. A pulse oximeter is very useful and supports the caregiver as they assess the newborn's SpO2 and helps them to determine the level of FiO2 or oxygen to provide to the infant. We're going to initiate our chest compressions if the heart rate does not respond to all of our ventilation efforts. And this includes corrective steps that we're going to use with Mr. SOPA. Making sure we're aligned, making sure we have good mask to face, and ET tube placement. Our epinephrine dose has been updated. We now have the option of just one dosage. You can still provide 0.1, 0.2, or 0.3 milliliters per kilogram, but in order to support caregivers, they now offer the one dose option of 0.2 milliliters per kilogram IV or IO, and this is now followed by a 3 milliliter normal saline flush. Epinephrine is given if there's a poor response to chest compressions. Caregivers can now consider discontinuing their resuscitation efforts after 20 minutes. And this is after all of the steps of the resuscitative process have been completed and there still is no heart rate. At this point, I would like to offer up some question and answer period. And I want to thank you all for joining us today and taking time out of your schedule, because you are important. And I want to thank you all for taking care of some of our most fragile patients.
Thank you, Maria. If you click down below, you'll see the Q&A chat pod. There are some questions in the chat pod already.
Okay, yep, I see them. So Ahmad, you can sign up for NRP course classes, and it's quite easy to do it on the internet. The RQI is right now being tested in hospitals, and so there's already a lot of hospitals doing the RQI. But as far as the NRP program, I think if you contact the American Academy of Pediatrics, they will set you up with signing up for a course near you. All right, Emeline asks, when you have reached the point of starting chest compressions, heart rate less than 60, when do you stop compressions? So this is more of a decision that the team can make. There is a lot of people involved in trying to decide when to stop compressions. So I see that you're saying, do you stop when it comes back over 60, or do you wait until the heart rate is above 100? And I believe that you're continually assessing. And so if you feel like you're getting good ventilation of the baby and the heart rate is coming up, you should feel comfortable stopping compressions. But if you feel like the compressions are what is assisting the baby in keeping the heart rate elevated, then you should continue and then move on to the next step, which might be epinephrine. But if you're, I am not an expert, and in scenario testing, there's a lot of different scenario testings that NRP provides. And this is one of them, or it could be one of them when you're receiving your certification, that they're talking about when do you stop compressions and when do you back off. And we are, so phone number here, we are used to keeping newborns warm. How would therapeutic hypothermia work with a newborn? So yes, when we're doing our resuscitation, usually we have the baby underneath the warmer because we're making sure that the baby stays warm. That is part of the resuscitation process, is warming. And so when you're done with your resuscitation efforts and the baby is stable enough to be transferred to a unit or a facility where they're going to continue to be supported, that's when the provider usually says this baby is a candidate for hypothermia, and you would ask how he wants to initiate those steps for providing therapeutic cooling. And a big thank you from Lee. Thank you, Lee, for coming today. Let's see, any more? Yes, so Sean says, thanks much. John says, are there any new guidelines for mechanical aspiration? And I have not seen any new guidelines for aspiration. I do know that they mentioned several times that we're trying to reduce the amount of meconium aspiration. We're trying to reduce the amount of suctioning we're doing on these infants because it can be so traumatic. But we would still follow the same guidelines that you follow in the past. Does NRP include a trial of INO? INO. Wish I could tell you the answer to that one. If you could be more specific about what INO is. If you have questions directly for NRP, they're very good to work with, and they have easy access by email and phone. So if you're thinking that you want to talk to them about that, it would probably be a better idea. And you may have answered this already. Do we have to sign up for RQI as well? So usually with this RQI, it's your facility that's setting it up, because they're bringing in the RQI people who have the simulator. And so reaching out to RQI directly, if you're a provider, they have a lot of great information on the internet, and AAP supports them. So they also have a lot of great information about RQI, and they're setting people up with RQI right now. So this is a great time to reach out to them. Yep, I figured it out, meconium. And back up. Oh, nitric acid. So that was trial of nitric acid. I didn't dive deep into advanced practice, and I'm not sure how much they talk about nitric acid in the resuscitation process. I don't see it in the essentials for sure, and it's not part of the algorithm. So they may not mention nitric until, and if they do, it's just a little bit further on. And you're welcome. How can I order an 8th edition book? So NRP, the website is fantastic. AAP, American Association of Pediatrics, is where I went and got the online 8th edition book. And you can also order a hard copy 8th edition book from American Academy of Pediatrics website. So Susan asks, for the advanced learner 2-year credentials, will it be mandatory to do these quarterly RQI? So it really depends on your facility. You still, the facility is deciding, should you stick with the traditional method of instructor, which probably most facilities, it'll be easier to stick with what they already know. For larger facilities, I know that that's where they've been testing it, because there's so many people that have to get through the process of renewing their credentials, and it happens so frequently that to have the RQI set up to do quarterly is great at helping them maintain their skills and earn their credentials. So as far as the advanced learner goes, you're still doing it every 2 years. And you're probably going to be helping your facility provide the RQI skill stations, if you're set up with that, or if they are deciding to set up with that. And if a baby qualifies for therapeutic hypothermia after resuscitation, minus compressions based on best practice guidelines, but the doctor wants to warm the baby and get an ABG after they are warmed to see if it's metabolic issues, what would my suggestions be? Ooh, that's a good one. Didn't mean to get into this today. Really, so many decisions have to be, you have so many different considerations to take into account when you're making these decisions. And oftentimes, you know, when we're working with these practitioners, it's just going to be based on what they think is the best option for the baby. It's just in knowing that these options are out there and available now, and providing any kind of information you can in order to get more people aware of what the benefits of therapeutic hypothermia is probably our best bet, because not everybody really understands all of the benefits. And it's still really new for a lot of us too, to be providing this therapeutic hypothermia after resuscitation. We just have to weigh what the benefits and risks are for each instance. And I think it's just going to take time. But if we're looking at more research and we're paying attention to the studies that are out there, then you probably will see it used more often, and maybe at your facility. And surfactant. So yes, NRP does discuss surfactant a little bit in the advanced practice part. So in lessons 5 through 11. And I didn't research that as much, but I know that they're still recommending surfactant at a certain period of time during the resuscitation process. And is RQI mandatory? No, it is not. And thank you for this update. Let's see, anonymous, thank you. Victoria, nitric acid, no established role in less than 35 weeks gestation. Near-term infants can use this. Thank you very much for answering that question. So I believe we're in good shape.
A couple in the chat pods. I have one from a Danielle.
Oh, good Lord.
As a NRP instructor, if we have to re-up our instructor status this fall, should we do the new edition or do the current 7th?
So instructors actually don't have to renew until they're up for renewal. All they need to do is be up on what the updates are so that they can incorporate them into their education. So it's only if you're up for renewal that you need to renew when you're an instructor or advanced practitioner.
I guess part of this is if, like, I guess if you're saying the new edition isn't in, I guess, taking effect until January 2022. So if this fall they would still be using the 7th edition. Then,
correct.
Okay. Let's see. There's something from Sherry. What is the approach for LMA? I'm not sure if that.
Okay, so LMAs are available, and if you feel comfortable using them, they're actually there's instructions for using an LMA and along with positive pressure ventilation, and this is part of the resuscitation process. If you're unable to get an ET tube, they can be using the LMA in order to get your airway during resuscitation. So if no one's available to do an ET tube, that LMA is the other option.
Thank you for the update. Wait, let's see. I do see one more question. How long do you bag APT before deciding to intubate to avoid putting air in stomach without an NG?
So NRP follows the guideline of when to move on to intubation. If you're unsuccessful using bag valve mask and you've done Mr. SOPA, you've done everything that you can, and you're not getting good ventilation with heart rate rising, you should move on to intubation or laryngeal mask. So that's the guideline, basically, is the heart rate and is the baby responding to your ventilation support. as far as inserting an NG tube, they don't get into that as much. Yes, it's often needed when you're providing ventilation support, but the earlier you can move on to ET tube insertion or laryngeal mask in order to support ventilation, if you're providing that assistance, it can be more helpful when you're trying to get that baby stable. They do not mention insertion of the G tube at that point yet in the algorithm. It takes away, it may be taking away from other things while you're trying to get that heart rate up.
All right. Well, thank you, Maria, for a very informative presentation. We hope to have you back again. I think we've covered everyone's questions so far today. Thank you, everyone, for joining us.
Yes, thank you, everyone. Have a great rest of your day.